Good afternoon, everyone, and thanks for joining in. I'm Ellen Mason with the California Medical Association, and I will be your host for today's webinar, the third installment of the Data Exchange Framework series, Deep Dive into the Data Exchange Framework and Data Sharing Agreement. Please submit any questions you have throughout the presentation by using the question box in the control panel, which is located on the right-hand side of your screen. We will go over questions at the end of the presentation. Today's presenters are Deanne McCallum, Data Exchange Framework Deputy Director of the Center for Data Insights and Innovation at the California Health and Human Services Agency, and Bob Jordan, Senior Consultant at Mazars USA. First, I will turn the presentation over to David Ford, CMA Vice President of Information Technology.
Great, thank you, Ellen, and thank you to our presenters and attendees for taking some time out of your lunchtime today to join us on this very timely, very important topic about the Data Exchange Framework. As was mentioned, my name is David Ford. I carry two titles here at CMA. I'm the CEO of CMA Physician Services, which is CMA's practice transformation arm. I also carry the title, but probably more relevant to today, Vice President of Health Information Technology. Before returning to CMA in March of 2020, I was also the executive director of an organization called CalHIPSO, which I only mentioned today because one of my colleagues, while I was at CalHIPSO, was today's presenter, Deanne McCallum. So if we can go to the next slide. So as was mentioned, we have two very outstanding presenters today. Deanne McCallum, the Deputy Director of the Data Exchange Framework at the California Health and Human Services Center for Data Insights and Innovation. They are the organization within CalHHS that has been tasked with leading all of the work on the Data Exchange Framework. And then Robert Jordan, a consultant with Mazars, who has been supporting that work from the outside. So we're very lucky, we're very thrilled to have these two presenters. They are just the top experts anywhere on this information, and we appreciate them being here. Next slide. So as was mentioned, this presentation today is part of a series of webinars, and you know, as we build this series of webinars and we build other CMA resources related to the Data Exchange Framework, it really, really helps us if you let us know what you're thinking about, what your concerns are, what questions you have. So today, we will try to get to as many questions during our Q&A time as we can. So during the presentation, if you want to enter questions into the chat box on the right side of your screen, Ellen will read some of those out at the end of the presentation. But if we don't get to your questions today, or if you need a deeper dive, by all means, email us at that email address that you see up on the screen, dxfquestions@cmadocs.org. We log all those questions. That inbox is checked daily, and we do try to respond to all questions within 24 hours. One thing I do want to quickly mention, because it's part of our larger education campaign about the Data Exchange Framework, is that we are building a physician learning collaborative. This will be a group of physicians who work with CMA to share best practices, share learnings about data exchange as we move into that world. If you're interested in being part of that learning collaborative, or perhaps knowing more about that collaborative, to see if you would like to join it, by all means, send an email to that email address up on your screen, because we would love to have you. And then one more slide.
I think it's moving slowly. There we go.
This Data Exchange Explainer series started back in February and will go all the way to December. This is the third out of 6 presentations. If you missed either of the first two, not to worry, they are available on demand on the CMA website. Like today's presentation, those on-demand webinars are free and open to all, thanks to the support of the Center of Data Insights and Innovation. You see webinar 3 is today, and then in August, we will be talking about how to optimize your electronic medical record for data exchange. In October, we'll be talking about practice workflow. And then December 15th, we'll be talking about funding opportunities to support data exchange. So make a note on your calendar now. We'd love to see you back for all of those future presentations. And I think I said one more slide, but I think there is one more just to briefly touch on today's agenda. After this slide, I will turn it over to Deanne and Bob to go run us through today's presentation about the California Data Exchange Framework. Then, as I mentioned, we will get to as many questions and answers as we can at the end of the presentation. And then please do fill out our post-webinar survey. That is part of getting the feedback that helps us build our resources around the data exchange framework and making sure that they're responsive to your needs. So with that, I will turn the whole presentation over to Deanne. Take it away.
Thank you, David. Thanks for having me today. Happy to join you all. So as David said, I'm Deanne McCallum with CDII and the Data Exchange Framework, and we are looking at implementing California's Data Exchange Framework. We're going to be talking about signing the data sharing agreement. There's, in this space, there's a lot of acronyms. We've tried to call them out each time. Subsequently, I'll probably be speaking them DXF for Data Exchange Framework. DSA is Data Sharing Agreement. How and what signing the DSA is about, who intermediaries are, grant programs, some slides that are specific, specifically tailored for this audience, and then showing and sharing some of the resources that we have over and above the resources that David already called out on the CMA side. You met us, so I'll jump right through. This is one of the slides that I tend to actually read through, very consistent messaging from Cal HHS, the vision for the data exchange framework. Once implemented across California, the DXF will create new connections and efficiencies between health and social services providers, improving whole person care. The DXF is California's first ever statewide data sharing agreement that requires the secure and appropriate exchange of health and human services information to enable providers to work together and improve an individual's health and well-being. Notice a lot of focus on both health and human services information. So it's a step above the, in a sense, the meaningful use years and the EHR adoption and the sharing of exchanging information, just clinical to clinical. What is the framework? We can pretty easily say what it is not. It's not a technology. It's not a required source that you need to use, not a required infrastructure, and it is also not a single repository. So it's not a centralized database where everything will sit and that others will have access to, but it does lay out the rules of the road. Lots of policies and procedures, guidance documents, programs, things like that, that are all parts of the rules of the road. And also, if I'm going too fast on anything, call me on it, and I'm happy to go back and elaborate and go into bigger details. The data exchange framework stems from legislation. We refer to it often as AB 133, and it was codified in Health and Safety Code 130290. So that legislation required that there be an actual framework, and that it include a data sharing agreement and policies and procedures and a strategy for digital identities. So the framework part requires and enables health information to be exchanged among healthcare organizations through any health information exchange network, health information organization, or technology that adheres to specific, I'll insert the letters DXF standards and policies. So that's where it is not a specific technology. It is through any of these types. There's different ways to be able to safely and securely exchange the information. The data sharing agreement and the policies and procedures spell out the standards that were just mentioned above and cover the governance of the information exchange. And the strategy for digital identities enables health and social service organizations to match shared individuals while keeping information private and identities secure. So what we did last year, before I was on a member of the CDII team, but at that time I was a member of the Implementation Advisory Committee, which CMA also has a seat on, and the predecessor, the advisory group. So CMA, myself under my previous positions, have been engaged on the data exchange framework for a while, and that's where one of the directives was to create a strategy for digital identities. It doesn't mean that we have that completely stood up today, but it is being worked on. I think sometimes I have to click in before I can advance it. The data sharing agreement and the policies and procedures govern the exchange among healthcare entities and government agencies. So this is a record, a list of the different policies and procedures. The ones on the left that are published are, I think it's 8 of them, that were published according to the legislative requirement to have them published by July 1st of 2022. So they're nearing a year old. And that is, there's a policy and procedure for how to amend the DSA, how to modify policies and procedures. So these both touch on essentially some of that governance, like how does this work? Who has the authority to do what? Breach notifications, a technical one, permitted, required, and prohibited purposes. So it's like, what exactly? So in that kind of on the compliance side of the house, what is permitted to be exchanged, what is required to be exchanged, and what is prohibited to be exchanged. So all of that is in this one policy and procedure, which you also might hear me call a P&P. And then what is the requirement to exchange health and social services information? So similar, but its own standalone policy and procedure. Privacy and security safeguards, individual access services. So how does an individual who may be a patient, who may be someone who is receiving services on the social services side, how are they able to access the information? And data elements to be exchanged. So that's a good technical one, like where people ask what are the standards of the technical elements. So that would be the policy and procedure to start with and read. Ones that are currently in development and they're in different stages of flight is California information blocking prohibitions. This was named from stakeholder input suggesting that we call out the California DXF nature of this as opposed to the federal information blocking rules, which we do use those as our baseline, where we do part of the original legislation says adhering to federal rules and regulations and laws, and we definitely keep an eye on all of that. So, but we did want to call out that this is not we're not only using the federal information blocking, but they are our baseline. Early exchange, what if anybody exchanges sooner than they're required to under the framework? Trying to shape what is real-time exchange, most notably because that's one of the things that AB 133 is trying to accelerate and advance. And within the legislation, it calls out that the goal of the DXF is for real-time exchange. So we're working on a policy and procedure on that. Technical requirements, so that just takes the data elements to a whole new level. What are the actual technical requirements for exchange? A lot of people will ask, like, how do I know how to exchange and what do I need to have in-house to be able to do this exchange, or what do I need to be a customer of or licensed to use? And then a QHIO, Qualified Health Information Organization program, that I will be sharing with you a slide or 3 on that as well. Those are all on our website. That when Bob is talking, I'll see if I can share the link with Ellen if it's not in the slide deck, and those are all accessible, quick, easy links. They might not be, we don't have the best website, but they're in there and we can help navigate and show you. And I suspect the CMA resources also help people find the policies and procedures. Important dates and timelines of the data exchange framework. It was passed into law July of 2021. It had requirements that it be basically existed and shaped by July 2022, so that those deadlines were met. This past January 31st, 2023, is that all required or mandated entities listed in the statute sign the data sharing agreement by that date. The signing portal is still open. We'll cover some of that this hour, but there was an actual deadline. So if you're required signatory and you have not signed, you're not compliant. And we encourage folks to sign. There is no penalty to be signing late. We welcome you and encourage folks to sign. This winter and spring, we've been working on the educational activities such as this webinar, some funding to help lift these up and make resources and host sessions and conferences and things like that. A lot of activities been going on with 8 different educational grantees, and everybody can share resources in that space and share them out to their members and everything as well. We're working on a grant application for technical assistance and qualified health information organization onboarding. So that grant window is open right now. It closes tomorrow, but don't worry if you don't have an application started to submit for tomorrow. There's 2 more rounds coming. So about 2 weeks or so, late June, we'll be opening round 2. So pay attention some this hour if you haven't heard about this grant program. We'll be announcing who the actual qualified health information organizations are probably in August. Any of these timelines are subject to change except for the ones that are in statute, which is that January 31st one and the July 2022. Those are dates that I'm kind of note to self, I should put in different color boxes because those do not have moving dates. Neither does the January 31st, 2024, where the statute, the legislation says these entities must begin to share by January 31st, 2024. And there's a number of entities that I've done on the insert box on the bottom right that have an additional 2 years to exchange. And those are physician practices of fewer than 25, rehabilitation hospitals, long-term acute care hospitals, acute psychiatric hospitals, critical access hospitals, rural general acute care hospitals with fewer than 100 acute care beds, state-run acute psychiatric hospitals, and any nonprofit clinic with fewer than 10 healthcare providers. They are all of the entity types that are specifically called out in the legislation that have until January 31st, 2026 to begin exchange. They were not carved out or called out about signing of this year, January 31st, 2023. So that has confused a lot of folks that everybody who's listed as required must have signed by January 31st. And then these ones that were called out specifically have until 2026 to begin exchanging. Who must sign? So what I've mentioned a time or two, mandated signatories are required, and these are taken from the actual legislation. General acute care hospitals, acute psychiatric hospitals, physician organizations and medical groups, skilled nursing facilities, and they're the only one of the 6 required that have this extra that currently maintain electronic records. Healthcare service plans and disability insurers, Medi-Cal managed care plans are included in that, and often I'll abbreviate all that to payers. Some people do think that this is a Medi-Cal only exchange requirement, but it is all payers, though a lot of the origins of this was to help support CalAIM, knowing that CalAIM would be more difficult to succeed if there was not better sharing of health and social services information within the state. And then the 6 of the required signatory types are clinical laboratories. And I do think they have under this code 1265. So there is some kind of weedy nature within there to actually drill down into it. Probably is not absolutely every clinical laboratory, but the more the merrier. So far, more than 1,500 organizations have signed. So over 1,000 of those are the ambulatory care facilities, IPAs, practices, those types of entities, 140 hospitals, more than 90 long-term care facilities, more than 50 of the health plans and insurers, some clinical labs. We have a whole category of entities that we call voluntary because they are, a lot of them are on the social services sides of the house, the health information organizations, which are some of the intermediaries, community-based organizations. This list is available on our website, and it presents as though it's an Excel file, and you can almost play with it live if you wanted to. You can download it. I'm assuming CMA does some work with it where there's various different columns of information for what type or subtype that an entity selected when they were signing. But it's helpful because you can find folks based on zip code, by name, parent name, subordinate name, if that information was entered into the signing portal. What does it mean to be a signatory? It means that you will have access to key clinical and social services information from healthcare providers, plans, long-term facilities, labs, and other signatories. You can be alerted to hospital and emergency department admissions and discharges for authorized individuals. You become a partner in sharing your key clinical and social services information with others to help coordinate care. And you share in the trust of a common data sharing agreement, as well as the common policies and procedures that require everyone to share and protect data according to a common set of standards. Within all this and in the legislation is that this is still all based upon TPO, treatment, payment, and healthcare operations, and public health driven needs for data exchange. So it does still stick to applicable laws and rules and reason for exchange. It does not crack that wide open and come without guardrails. So how do you sign? I'm not sure if we're pivoting, but let's just have a quick look.
Let's pivot.
What's that?
I say let's pivot. I'll take it here for a few and you can catch your breath.
Okay, great. Thanks. On to Bob.
Hello, this is Bob Jordan, and signing the DSA is a simple mechanical effort. It requires a little thought before you go into it, and we'll go over that. You can reach it through the CDII website, so you don't have to write down the URL that's shown here on the screen. But certainly through going to CDII, looking it up, and click, it'll take you to a screen that looks like this. Next slide, please. Before you start, you'll need to think about who's going to sign the DSA in your organization. If it's a simple small office, then that's pretty clear. If it's a larger organization, you may have other subordinate entities that are required, and a single signatory can sign on behalf of multiple entities. So thinking through the organization up front helps. Then you need just the simple information about who's signing, the name, the address, the contact information, all the usual things that you would enter in. The only two secret numbers you need are physician organizations and medical groups would enter the EIN or the tax ID number, and that becomes the unique identifier for them. Or hospitals, health plans, etc., would list their license. And so that's the most common question. Next slide, please. What license are you referring to? Hospitals, of course, have license numbers from CDPH. Healthcare plans might have a license issued by the Department of Managed Healthcare, Department of Insurance, or they might have a risk-bearing organization number, or they could be contracted by DHCS, in which case they would have a separate number. Clinical laboratories get a CDPH number. Yes, the feds do have a CLIA number, but that's not the number that we want to gather here. We want the California's CDPH number. So that's very straightforward for laboratories. Next slide, please. Now we get to the harder part. What is a subordinate organization? It can be a related organization. It can be a peer organization. For example, a health organization, a health agency might have a hospital, a laboratory, or several ambulatory groups, etc. They're not necessarily subordinate one to the other in any hierarchy, but they're all certainly related to the so-called primary or parent entity. In that case, you can have a single parent that would sign for all of those other organizations. And if you happen to be at the same physical facility, for example, as shown here, an acute care hospital that also includes a licensed clinical lab, so you've got two separate entities, two separate licenses. You could list the hospital name as a primary, and then also list the hospital as a subordinate with its license number, and the laboratory with its license number. If there's a separate standing part skilled nursing facility, you could list it as a subordinate with its license number. Question, if you're a federally qualified health center, do you have to list all of your sites? No, because you're a single integrated financial entity. The entire FQHC can be identified by a single tax ID number. So that makes this simple for an FQHC. That means that it takes about 5 minutes to actually do the DSA for an FQHC or any small entity with no subordinates, because you simply log in, select your type, put down your name, put down your contact information, and click Send DSA. It'll come to you by way of an Adobe Sign document. You can click the sign. It goes back into the DSA signing portal, and you're finished. So start to finish on the order of 5 minutes. So it's not a difficult process, and it's entirely self-service. It gets more complex if you have a number of physical entities. For example, one of the health systems has 26 subordinates. And so that took a little bit longer to fill in the name and address and type of each of those subordinates. But it's all a matter of deciding a priori before you start just exactly what your organization is. Next slide, please. And we're back to you, Deanne.
All right, I had to find the unmute. I mentioned intermediaries a bit ago. Thank you, Bob, by the way. QHIO is an organization that offers services and functions supporting the exchange of health and social services information, has demonstrated their ability to meet all data exchange framework requirements. So that's what's different, would make a QHIO different than an HIO. HIOs exist today and have existed for at least a couple decades, some of them, if not more than a couple. Provides technical and programmatic capabilities and enables participants. So that would be a data exchange framework participant, and you're a participant once you're a signatory to the DSA that Bob just spoke about, to comply with all of their obligations under the DSA. Participants are not required to use a QHIO, but we are highlighting them here to show that they are a level of an intermediary that had to go through an application process with CDII. We're working on opening up the application window for organizations that want to apply. They do not yet exist, but we've had some public comment windows on a policy and procedure on the QHIO program. And developing a program document, guidance document type of thing, and an application. So they've all been distributed and published for public comment. We've accepted those comments, are reviewing and iterating, and will be releasing an application for entities that want to apply for a QHIO soon. So you cannot leave this webinar today and get a list of QHIOs because they do not yet exist. But there's some entities that you can probably do some research on to learn about them more if you don't already use an HIO. So if you choose to use an intermediary to exchange under the data exchange framework, know that they are required to have services enabling you to meet your data exchange framework requirements. They must share with each other. So historically, these entities are very competitive, but it's a new day and very transparent and open and yet secure. And for the right reasons, information is being shared, and the QHIOs and the HIOs within California have all stepped up. They're not required signatories. QHIOs are required to sign, but HIOs are not, and a number of HIOs have already signed the DSA. There's some of those 1,500 who have signed, and they will provide statewide sharing and access amongst data exchange framework participants. They must be able to share with nationwide networks. They also note that they also provide data and services beyond the requirements of the data exchange that may be valuable to you. So I highlight that because maybe they offer some pop health management features or some dashboarding or something. Those are not components of the data exchange framework, but know that they might be services and value add aspects to your world. A decade ago, I was probably in the camp of people that thought EHRs were our solution and our one-stop shop. I think we've all come to realize it's a little scary to say, but we need more. They're not doing everything that we need, and that's what some of these intermediaries and more modern, newer technologies are feeding off of what the electronic health records are capturing and taking it all to a whole new level. And then QHIO onboarding grants are one of the two of the signatory grant domains. So you can also have some funding to help supplement your onboarding to a qualified HIO. You can't use that funding for an HIO under that domain. There's another domain if you want to go with an entity that is not qualified. It does not mean that they cannot still do the exchange under the DXF. It's just that either they did not apply or did apply and through the summer review of applications and scoring by CDII that they might not have earned a Q. So I've mentioned the grant programs. I'm not going to go too long into this education services slide, but this is a place to go and find some of the resources that David shared earlier on. To qualify for a signatory grant first off you need to have signed the DSA. We do have this application portal that is open, and entities that are allowed to attest in rounds 1 and 2 or apply in round 1 and 2, apply for review and awards are the ones who are the required signatories. So everything with the orange check marks, that clinical labs, acute, psychiatric, skilled nursing facilities, physician orgs and medical groups, general acute care hospitals, and the health insurance plans. I think I skipped those. It's self-attestation in the Grants Connect application portal. You choose the box. Counties are called out in the legislation to as encouraged entities for signing, and then the others are the same as voluntary organizations or some that might not know who they fall into. So this is a screenshot of what is a question in the application. We will be looking at when entities are required to sign. It doesn't mean you should not apply today or through this summer for a grant for technical assistance or QHIO onboarding. But your award might be structured and tiered for the when you need to actually begin implementation, or if you select working with a QHIO, they might put you on their project plan a few months down the road after the folks who need to start exchanging under the framework in January of 24. There's two domains, the QHIO onboarding and the technical assistance grants. So QHIO is an assisted pathway. So Bob's organization, on our header slide, it comes under Mazars, and they host and run the data signing portal for us, but they're also helping for being experts in the California Health Information Exchange world, and with the entity CAHI, the California Association of Health Information Exchanges. They're contracted and partnering with CDII to help applicants on the assisted pathway to do a QHIO, and that stemmed from listening sessions that CDII hosted in the fall of 2022, where people said, we don't have the bandwidth to do a grant writing request. We don't know enough about the IT space to be able to do this on our own. So this is where you would reach out to CAHI. You might get Bob as a result, but you reach out to CAHI and they will work with you one-on-one to submit your grant for the onboarding to a QHIO. Or some may choose, and the funding goes to the QHIO. So that's another thing people they didn't actually want to manage the funds of a grant fund, but this would go to the entity that you would be signing on to use as your exchange intermediary. And then there's technical assistance grants. You build your own. There's required outcomes where you would need to hit at least one of them, where you have contracted for a technology solution, you have implemented a technology solution capable of supporting real-time data exchange, and that implementation would have come at a cost, and that's what you're applying for a grant for, funding to help supplement that cost. Adjusted, upgraded, or adopted an electronic documentation system. So maybe you have been using something that is not quite up to par and you want to upgrade it. Maybe you've never used anything and you need to adopt it today. This is where some funding can help you with that. Or that you have created or provided training for new workflows. So maybe you have a system and this and that, but you want to hire a consultant or do earmark someone on your staff to work, or hire somebody for an internship to do a special project for you. So that would be an example of how you might be able to utilize technical assistance grant funding. And you do your own application, and the funds come directly to you. There are different funding maximums for the different types of entities that are involved. A lot of this has come over gauging what funding has already been invested in certain segments of the data exchange framework entities, and then also what's known size and needs are. But there's baseline funding, and then if you are eligible for enhanced funding based on serving the underserved and not having participated in the California Health Information Onboarding Program that was referred to as CalHOP, then you're potentially eligible for enhanced funding where the baseline ceiling is elevated some, and that's all part of the grant application process and our guidance document that we have. So if you're wondering about this, and also similar to the data sharing agreement that we spoke about before, instead of going into a portal and being live and logged in, you can go to CDII's website. Maybe David has it already out on the CMA Data Exchange Framework resources. You can pull down a copy of the DSA and go old school, print it and feel it and read it if you want. It's about 9 to 11 pages. You can also go to our website and print a copy of what the grant application portal has in like the online world, but we have a document that is the application. So you can sit through and go through and read and understand either what CAHI will be working with you on, or what you yourself would be needing to fill in for the technical assistance. Both domains go through the same application. And then we have a signatory grants guidance document. So it's a little thick, it's a little detailed, but I've seen longer documents. It's about 40 pages long. And it has a lot of different information in it about the grants program. So those are 2 resources that you can find on our website. All righty, so some of the benefits of the data exchange framework. We are recommending people view it as an opportunity, not so much just the law or a mandate or a requirement, but let's turn that around and view it as an opportunity. All healthcare providers and plans must participate and must share key clinical and data and notifications with all other authorized participants. So other folks who have signed the DSA and who have a reason for requesting, which is in those PMPs earlier mentioned. It's a unique opportunity to have access to data more timely. We're trying to get the right information at the right place at the right time so that we can improve the care that we provide and the services. So it's not just clinical in nature, remember. Data exchange framework requires all participants to share following the US data core data for interoperability. You might hear some of us call it USCDI, and often we might forget what those letters stand for because it's such a common acronym for speaking, USCDI. The USCDI establishes a common set of data elements and terminologies, common language for all participants. So it's part of you'll find that in one of the, probably in the technical requirements or the data elements to require policy and procedure. The data exchange framework establishes common standards for digital identities and person matching, so participants can have more complete, accurate linkage to an individual's data. We are still working on the digital identities and person matching, but they are projects that are well underway and definitely being worked on within CDII. QHIOs are designed and poised to help data exchange framework participants meet data exchange framework requirements. So again, HIOs are not created for data exchange framework, but the Q, hooking the Q on front of them takes them to another level that is very specific and centric to the data exchange framework. There is a path for data exchange framework participants to use their current systems to participate in standards-based statewide data sharing via the QHIOs. And social services and social determinants information are to be included in the data exchange framework. So key social determinants may soon be data elements included in the data exchange framework. Some of the social data that people are focusing on, and that is important information, is within the USCDI, but there is even more that we all know is out there and captured and collected or should be, and that's where the framework will be able to grow with the times and add different data elements and things to what are the required data elements. Alrighty, let's see what's next. Legal and privacy considerations. So the data exchange framework must protect individual privacy and data security. Nothing in the framework overrides current requirements for public health reporting. Current standards and methods remain, but may be enhanced by new real-time sharing. The main thing is that nothing overrides. Data exchange framework does not require sharing in data in a way that would not be allowed under applicable federal, state, or local law or regulation. Current protections for individual privacy are still in place. Individual consent may still be required in some use cases, and individuals may still decline to have their data shared. The framework and CDII does not drive that. That is still on the entities that are essentially the owners of or those who maintain this data and your relationships with the individuals or the patients. The HIPAA privacy standards and security safeguards become the floor for most data exchange framework participants, even if not bound by HIPAA, including the social services participants. All must protect individual privacy by following a common set of well-established rules that are within the terms and conditions of the data sharing agreement, the policies and procedures, and all federal, state, local applicable laws. The data sharing agreement is a common data sharing agreement that all participants must sign, but does not replace a business associate agreement for business associates. Many exchanges however, under the framework are not as business associates and may not require a BAA. So that is something that we flag to make sure that you're informed about and know, and make sure you look at your BAAs and whether they fit or if you need to add ones under the data exchange framework. I think we still have a few slides, so steady forward. Myths. So we do have some myths and facts versus fiction. Many mandatory signatories can request an extension beyond the January 31st, 2023 deadline. Neither Cal HHS, the Health and Human Services Agency, nor CDII have the authority to grant an extension. I briefly touched upon earlier that there is no penalty. So though it's beyond that date, I do still encourage you to sign, especially if you are a mandated signatory. And we cite which part of the Health and Safety Code. It's section little f that lists the 6 types that are on the earlier slide about who must sign. The DSA's policies and procedures were developed with limited public input. So that is some of the feedback that CDII has received over the last 6 months or so. They have all, however, been developed through an open, public, and transparent process. We post them for public comment. We collect public comments. We review those, and those comments are also posted on our website. Some are under the archive section, but they are still there. Input is solicited on drafts of the policies and procedures at public meetings and through written public comments before being finalized. And even with the public meetings, folks can, if an official public comment window has opened, but then we discuss them again at a subsequent public meeting, there's an opportunity for folks to email or use the chat feature and question, and even have the floor to also contribute more comments. Mandatory signatories do not have to sign the DSA because the PMPs may change. And that is a myth as well. It just says that they must sign by January 31st. This is the regulation of 2023. As with every framework, policies and procedures will develop and change over time as the needs of participants change, industry standards evolve, best practices advance, and federal requirements expand. The process for amending the PMPs was established in the data exchange framework modifications to policies and procedures last July. So we also recognized a year ago that we were finalizing, CDII was finalizing policies and procedures, but that there would be moments in time to modify and amend those. We're even working on a glossary of all terms that cross that occur in the data sharing agreement and the 8 final PMPs right now, and we're pulling those out to make one reference glossary of data exchange framework terms, and that will actually hopefully lighten the load of reading the policy and procedures and make them shorter, briefer documents, but yet still completely transparently saying, and here are any terms that you're not familiar with. But I bring that up because that's an example of modifying and revising a policy and procedure that was previously finalized. Like, we realize this should live and breathe and move and change over time, mostly so that we can improve upon it. The DSA and the PMPs require entities to use an HIO, so they are not required. There's a couple slides on that, and though I did focus QHIOs focused on their value and their opportunity as opposed to there being a requirement. Data exchange framework requires signatories that are HIPAA-covered entities to share protected health information with non-covered entities against the law and without protecting the information. So as stated, that is the myth, one of the myths we hear. And the reality is that it does not require covered entities to make disclosures in violation of HIPAA or any applicable law. It does not require covered entities to make disclosures without patient authorization if applicable law requires patient authorization. So even if you are a signatory and a participant of the DXF, and another signatory participant reaches out to you to request information to be shared under the framework, if applicable law requires for that patient to have authorized that sharing, you still need that authorization. The framework does not undo that. Covered entities are not submitting data to a state database that non-covered entities can access. So that's definitely one of the early days myths that folks were saying, yeah, but if it's in a centralized database, any participant can dial in and pull out from that information, and that is not how the framework operates. When PHI is lawfully shared to a non-covered entity through the data sharing agreement, the non-covered entity must also abide by all policies and procedures that a covered entity does, including the privacy and security safeguards. So that's where there are the social services, there are entities that everybody knows are not covered entities under HIPAA, but they have signed the DSA, which binds them to all the terms and conditions of the DSA, which also includes everything that's within a policy and procedure. Exchange under the data exchange framework is between entities that have signed the DSA. It will not be with entities who have not signed. And like covered entities, non-covered entities can only request information for the purposes allowed under permitted, required, and prohibited purposes. So that is a great PMP to look at and to read. And that's where within it and within, I think within the DSA, you should see the TPO and public health component. We do have resources, so this will be shared certainly by CMA with you all, this slide deck. One good one is to call out the State Health Information Guidance document. We call it the SHIG, S-H-I-G. It has existed for probably at least 5 years. They're long, they're volumes for sure, but they have some really good scenarios. And if you've never heard of the SHIG and you're interested on some state information guidance, it's guide, it's not requirements, but it's really helpful resources. So there's links to all of those. And then this slide is just an example of one of those spotlighting behavioral health information. So there's one that is specific to behavioral health, and definitely recommend people open that up and look at it. It contains 22 different scenarios from real user stories. So if you've never heard of the SHIG, do recommend browsing it at the very least and awareness of it. And then we have the CDII Data Exchange Framework website. We are also standing up another one that is a more consumer public facing one that should have good information, but all of it will still continue to live and breathe in cdii.ca.gov. I won't read out the rest of our website, and you can find all of the links, many links to many things. You may email us if you can't find something. We have information of Power webinar series. We have our advisory committee meetings and policy and procedure subcommittees that the public is always welcome to attend. So that's what I have right now, and we'll see if we have a couple minutes for questions.
Perfect, thank you. We do have a few questions. The first question, I have a surgical practice and do not use or plan to adopt an EMR. What do I need to do to comply?
You need to find a way to be able to share the information that is requested of you once you have signed from another participant who has the reason for that. So we do recommend that perhaps you adopt, perhaps you look into the grant program to help accelerate your technology, but you can make your own choice of how you want to get there. And then otherwise read the policies and procedures and the data sharing agreement. Collectively, that's maybe 30 pages to read, except for the tech requirements one that will be published soon if it hasn't yet published. That one's a little longer, but read those documents to see how would you exchange if you didn't change anything in your practice today. That's kind of the lens I would look at for that.
Great, thank you. Next question. Can patients opt out of the data exchange altogether? What is the best way for them to opt out?
That is dependent upon how your organization currently offers a patient. So it goes in part to what I spoke about on the slides with authorization, and one of the myths about opting out. So it's really about the entities that sign and are participants in the data exchange framework, whether they are accurately controlling and rolling out how they exchange information, actually pre-data exchange framework rules of the road, under HIPAA and other authorities of consent, opting out, authorization, that whole world. So it's not so much under the data exchange framework, but they will know, individuals will know who has signed and is a participant. So say I go to Main Street Hospital as an individual and I had to go there this weekend and happened to know about the framework, looked at the framework, and I see Main Street Hospital signed up as a participant, I would go to Main Street Hospital to talk to them about, what did I sign Saturday morning, and am I openly sharing my information, or did I sign something that said I do not consent to this, to exchange of my information, as opposed going to the provider of the services, whether it's social services or clinical, as opposed to coming to CDII or the framework for that opt-out.
Thank you. Next question. What is the role of the QHIO?
The role is to actually be an intermediary to exchange, so a network of networks, that they're a hub and they would do more of the lifting for entities that become members or participants of them. Participants of an HIO is a legacy term. Under the framework world, we tend to use a lowercase p, talking about a participant of an HIO, whereas a participant with a capital P under the framework is equivalent to having signed the DSA. But different signatories, different entity types can all use the QHIO to do the exchange for them. So it's a many to one, and then those ones being the HIOs and the Qs. And the Qs have hit a higher level benchmark of being qualified for demonstrating that they are absolutely meeting all of they're providing services that allow you as a participant of the data exchange framework to meet the needs of any data exchange framework request for exchange.
Perfect. And here is our last question. What is the deadline for the grant? And if we decide to work with technical assistant grant, are we responsible to identify QHIO/HIO work that works with them to integrate for data exchange?
I'll splice that up a little bit. The deadline for the first round of the grant window is tomorrow, so that is soon. And it's tomorrow night. For a little while, there was fake news that it was noon, but it is midnight, come to find out. So it is open all day tomorrow. It will open again in about 2 weeks. We wanted a pause. We wanted to review our guidance document, update it. We wanted to get to reviewing initial applications, make sure the folks that this technical assistance funding, it's a $50 million program, are aware and that we're hitting the right market of people who are in need for this technical assistance. So that is the reason for a break between round 1 and round 2. So tomorrow is the first deadline. It will open again late June, and we have plans for it to be open at least through July. You can be reading the resources and whatnot in between. So I do recommend that. Technical assistance grants are the ones that you would drive your own and do your own application, the guidance document, and even the application kind of help guide you along to what the different types are of uses of the funding. And the guidance document also calls out, and I believe CMA has a shorter abbreviated type of version of guidance, but it calls out what you're not allowed to use the funds for. So a lot of time, often, what you're not allowed to do is more straightforward. And then the QHIO grant. So you would work on and lean on KHI to help you walk you through the process, inform you, give you some background. They do a pre-assessment call with you. I equate it a little bit to like TurboTax or H&R Block. Like, you can't do TurboTax, that you can't use that nice, savvy, easy to use software if you're not plugging in the information. So you need to go do that. Or H&R Block cannot do your taxes for you if you don't supply them with the information. So KHI is there to receive and talk with you and guide you and collect information from you that they will then put into the Grants Connect portal. At the time of applying, you do not need to name which HIO you intend to onboard with. You can name one, and if for some reason your HIO of choice was a company named Walmart, and Walmart ends up not applying for a Q, but we awarded you a QHIO onboarding grant, we would reach out to you and say, well, sorry, Walmart never even applied, so here's the list of who the Qs are. You can choose from one of them, or you could stay with Walmart and switch to a technical assistance grant. If that scenario happens, we'll help walk you through it. Otherwise, you could, what if Walmart did apply and did not get a Q? We would also contact you and say, well, they're not qualified. You can stay with them. We recommend you make sure you dot the I's and cross the T's that they can help you meet your data exchange framework requirements. And you can switch your funding to a technical assistance grant and use that funding to help you work with this non-queued Walmart. Or you could select a queue, just like the other scenario, of somebody else, a non-Walmart who did earn a queue. And nothing against Walmart, it's just a very good agnostic example of a company name.
Thank you. That's all the time that we have for questions today. We have recorded today's webinar and it will be available on demand on our website tomorrow with a link to download the slide deck. A brief survey will pop up after this webinar ends. We would greatly appreciate your feedback. All of our upcoming webinars can be found on the CMA homepage or at cmadocs.org/events. Our next webinar on Tuesday, July 18th is titled Demystifying the Medical Staff. Recordings of past webinars can also be found on the CMA website at cmadocs.org/webinars. Contact us at events@cmadocs.org with any questions that you have. Thank you.